Oh, ain't nothing wrong, okay?
Hello, everyone, and welcome to the next episode of the Black Scientists Cooperative. Today, we're going to be continuing our health disparities series. We're going to be exploring healthcare deserts and minority access. We actually have a very special guest this evening, Mr. Arnold Sandridge. He has over 28 years of experience as a scientist, specifically in the diagnostic space. And so we're so happy to have you here, Arnold, tonight. Thank you so much for being with us. Can you begin by telling us a little bit about, your background and your journey to becoming a scientist?
Sure. So first of all, it's great to be here tonight. Thank you all for having me. And I grew up in Chicago, actually on the South Side in the projects, and we had a few friends who were more academically focused, so that's what we wanted to do. And so as a young guy, I would go to the doctor a lot for something that turns out to be really nothing, but it turned me on to science. And since I was 5 years old, I wanted to do something with science. And so that's what I pursued. I pursued science, and to what you said earlier, yeah, I wound up doing, one of those science geeks, and I started tinkering with things. I was going to go to med school, and there was no question about it. And then I got my hands on research, and that really turned me on. So I was like, okay, I know that. Let me try this out for a while. Then I got stuck. It was fun. So I like discovering things, and most of my background was spent in infectious diseases. So a lot of the latest and greatest HIV tests out there, I was actually, me and my group, we have developed those for our company, and always looking for the latest mutants. And then we actually found another one not long ago. So I had a nice long road to becoming a diagnostic scientist, and then that also reaches to other things with COVID, for example. I am part of the a consortium here in Chicago that goes community to community to really explain, at first COVID itself, now talking about the vaccine and how safe and effective it is. So it's been a fun ride, and I'm really glad to be here tonight.
Well, we're really glad to have you, Arnold, again. So we're going to kick it off with a question and a topic that I know is near and dear to your heart, because I've seen you do some amazing things around this whole subject. Can you explain to our audience what health care deserts are?
Yeah, we've heard a ton about food deserts, for example, right? There are parts of Chicago that have no stores nearby. They have fresh fruit and things like that that we could consume and live a healthy life. Well, it's very similar to that with in many of our communities of color, and the data actually shows community of colors in rural America. There are problems where there are not many primary care, specifically primary care physicians in those areas, because they're the frontline people who really get in front of diseases, help people understand them, and help people manage them. Well, a lot of areas, unfortunately, have really few or none, and that is a desert, and that is a big problem in this country.
Arnold, it really is a huge problem. I just think about how it was a really bad problem before COVID, but then after COVID hit, especially on the South Side of Chicago, it caused the closure of a number of different departments within hospitals. It's really leaving one major hospital on the South Side of Chicago for a lot of minority folks to go to. So this is really a real challenge, to your point, Arnold, for people of color, especially Black people, and in urban areas as well as rural areas. So to kind of follow up to that, what are some challenges that you see that come along with not having access to adequate healthcare facilities.
Yeah, and before I really answer that, I want to add one more point to your last point, and that is, I mean, look, another major hospital is closing, like, in May on the south side, right? So it's going to even get tighter, and people have less places to go. So some of the major issues that come out of that is, as uncontrolled diseases, right? So people are sick, they have either, the problems are, okay, they have no money for, I'll catch a bus or I'll take an Uber. They may not have money for that. They may not have a car. So, it's a lot like voting, right? You change the voting place to 2 miles away, you X out a lot of people because they don't have transportation. Well, the same thing with this, those same people don't have a way to get to a doctor, right? So as a result of that, you have just runaway diseases, so many illnesses I'm sure we'll get into that are unchecked. And by the time someone gets to a doctor, I mean, you all see this, it's like, oh man, we have a big thing on our hands now. You have to always use the most invasive or the most advanced thing to try to correct that person and get them back to a place of health.
So my next question is, so how do you think that contributes to the overall health disparities amongst Black folks? So by moving those and creating a wider gap, what are we doing to our communities in that respect?
Yeah, if I could use an example, that's a great question, because if you look at an example, if I could use a live example, I don't know who I can mention or not, but there was a study done by one of my personal friends at Rush, Dr. David Ansel. It was interesting. Right before COVID hit, he and his group, they finished, this is around October-ish, finished the study showing what is the life expectancy difference between zip codes in downtown Chicago versus zip codes a few miles west of downtown. And the disparity was blaring. It was amazing. It's, not far from a 30-year difference in life expectancy. Just, of course, downtown is downtown. You know who lives there. They have access to many resources versus on the west side of Chicago. And just the number of years that's taken away from us just by that zip code change is absolutely amazing. And this is all causes of death, right? Most people will say, well, why? Well, right away, people assume violence, but it was not violence. It was access to great medical health was the key issue that popped up.
So in your, go ahead.
I'm sorry, Charlotte. You mentioned David Ansel, and the book "The Death Gap" is one that I'm familiar with, and that was a very interesting book, and it definitely described the disparities. Like it was really interesting.
Yeah.
So I guess I want to kind of delve a little bit into what do you think some of the contributing factors in widening these gaps are? I mean, what is happening? What is going on where, we are making those health deserts broader, wider, and more difficult to traverse? So what are some factors that are compounding this and surrounding this issue?
Yeah, it's interesting. In looking at some research, man, there's some factors that that are apparent, and there's some that just you wouldn't think about. Take many of you all are physicians, or you got your graduate degree, you get a PhD. Hey, that's one expense, right? But if you go to medical school, look how much it costs to go to medical school. And I am going somewhere with this, right? You come out, you owe a ton of money as a physician. And so what some of the research shows is some doctors go, yeah, I don't know if I want to practice over there because may not be reimbursed at a certain level to help pay,
Mm.
help live a certain life. So it was pretty interesting. And believe it or not, some doctors are, many in the United States are from other countries, right? And they want to live and practice where their native language is. So they tend to go back to their neighborhoods, right? So that's another factor. So the ability to pay, the one research says, hey, when they look at Black populations, particularly Black and poor Hispanic populations, physicians have some hesitancy of going to practice in that area. And the research summed it up like this. It says, being Black does matter. Isn't that interesting? If you're Black, it matters whether certain ones will come and practice in that area and deliver medical resources to that area, because they believe in many cases people are not going to be insured. And that another one, Dr. Joseph, is the whole insurance thing. It's people tend to be not insured or not insured adequately in our neighborhoods. And so the doctors and medical practices go, yeah, we don't know. So of course not in all cases, but those are different factors that contribute to why these deserts are there and why they are growing in some areas.
That's good. So here at BSC, our whole platform is trying to educate, get the information out for how, in order for, the Black community can make informed decisions. So with that being said, what can we do to advocate for access to the Black community? What can we do?
Right. Boy, I'm full of thoughts and words on this. This is because something just happened, right, with COVID, right? Something just happened with COVID. One of the things, I saw us do is we were able to get into those communities. How did we do it? We used community organizations. We sat down with those leaders I worked hard in the Inglewood area, for example. And how did I do it? I couldn't do it on my own. So what did I do? I got with one of the community organizations, reached out to others. I'm going to tell you, we have to mobilize to these community uh, outreaches, get with their leaders, and we've done this. And this is why was COVID our response to COVID perfect? No, nothing is, but it was effective in the end. We were able to get in with the community leaders, get their buy-in, because we know we can't get to those communities without those community leaders. So we actually have a great model that we need to grab to and never let go. And that is these hospitals, the healthcare providers, the companies, right? We work at a pretty large company, right? And these companies also need to get involved with these communities, the community leaders, and stand behind them. Let them lead the way into the communities. And I will tell you, this model, I saw it work. It has been quite effective for us actually interfacing. And if I may mention one more thing, the way we did it was you can't just come in and say, hey, I have information for you, right? It's when you go in, you had to answer some of their questions and solve for some of their issues. Like, for example, one of the things we did was, hey, we sponsored multiple pop-up food pantries, and we worked with those who were giving computers away to the children and all of that. And that got us buy-in, and now they were willing to listen. And we stood behind the community leaders all the way. And this is a model that could be used over and over. Now that we have these relationships, we have a way in.
So Arnold, in the beginning, you talked about some of the hospitals closing down in and around urban Chicago area. Well, I grew up in a rural area, and so to get to a hospital or doctor's office, you had to drive at least 15 to 20 minutes each way. Now,
Right.
that was if you had a vehicle, because of course we don't have any public transportation. There's no Uber or anything like that coming, to
Right.
the area. So, and then those hospitals they're not trauma. They're not for, big emergencies. Even though
Right.
they have their ERs, they're more than likely they're going to send you to, if you go in with a big problem, a big emergency, then they're going to ship you off to maybe another hour away, or
That's right.
maybe 2 hours away in some cases, like, just thinking about where I lived. And so when we're thinking about the placement of these hospitals and healthcare facilities, who's making these decisions? Who's saying, let's close this hospital, or let's not build a hospital here, but let's build one here? Or who's saying, let's open, a Planned Parenthood or a public health center? Like, can you speak to, like, who's making these decisions? And is there any community involvement and community advocacy in thinking about how those decisions come about?
Yeah. And a short answer, it would be not us, right? So
Yep.
yeah, it's
Yes.
right. When you look at and I want to use a term here, and then I'm just to present the term, and then I'm going to step back and get real basic. Health economic outcome research. So that is, and of course all of you know, but I want the audience to understand, that is how much good results do we get out of treatment per dollar spent. So as we spend money on healthcare, how does that translate to how healthy the population is based on that healthcare, right? Well, when you look at that, that's nothing but a calculation that says, hey, you got people who go to college and they're business people, and they go, hey, if we open a hospital here, I can project us making this much money. Yes, it is money driven. And but if we open it over here, we could project, this kind of money, right? Whereas it should be care and, do no harm, right? And all of that, right? It should be driven by that and how well we can take care of the population. Well, I give you something that's pretty interesting. If I could go to Affordable Care Act, which some people go, I like Affordable Care Act, but I don't like Obamacare, which is the same, right? So, so it's something interesting happened in the rural areas. Many of the southern states, they said, no, we will not allow the Affordable Care Act, or ACA. I'll just say ACA from now on. We don't want that here. Yeah, it was political, right? Well, if you fast forward to the last 5 years, those hospitals, many of them in the South rural area, and it is estimated, I think is somewhere around 60% of the rural America is a health desert. Okay. So it's something like that. So now, let's go back to Affordable Care Act or Obamacare. It was political. They didn't want it in many of those hospitals suffered and closed. It backfired. If you take it here to, Chicago, you go to Stroger and all of this. I remember when they first really started going with ACA, they were doing the numbers. They were like, hold it, this is the first time ever we've operated in the black, so it really helped, right? So where am I going? We have to step away from this whole thing. People are with business suits and everything are making these decisions, but they're not really thinking about us as people who need this. It's all money driven. the American medical system, as you all know, is money driven. Well, if you're like many of us, you can't play in that playground because you don't have enough green to influence which way it's going to go. And unfortunately, that's what it's really driven by. We are get back to this whole, how is the medical outcome per dollar spent? It's amazing. If you look at all the countries in the world, you would think America, with all of its technology and all of its know-how, would be toward the top. No, we usually come toward the middle somewhere because we spend a ton of money. And you can see how we are when COVID came out. Our healthcare output is not the best in the world, right, for the entire population. So we're stuck here answering these questions. Okay, how much money will we make? And all of this. So the people in business suits are the ones making these decisions, and it's not really based on how, what our needs are, what these people's needs are. It's really money driven, and that is a real problem. And that's not in all cases, but that's the majority of how it works.
Money, money, money.
Yep.
Well, listen, Arnold, this has been an extremely enlightening discussion for both us and our viewers. We really appreciate having you on. And
yes.
Yes. And I want to petition to our viewers to, you're listening and you're coming every couple of weeks. Please share this with someone else, but not only share it, advocate for these things. This is so important. It's so important for you to advocate for yourself and for others so that we can ultimately end these types of disparities. Educate yourself, go to your local alderman or congressman and voice your concerns. It's the only way that we're going to ever make change. Thank you.
May I add something before we totally close?
Yeah.
I want to echo what you're saying because it does lead to a few things. If I could just name them right quick.
Yeah.
And I didn't know where we were going, so I'll say this. You take our women, for example, our Black women, versus white women. Our white women are diagnosed with breast cancer more than Black women, but Black women die from it more. This is one of the issues. If you look at the main things that are killing us, right, is heart disease, is cancer, things like that, right? We, as Black people who represent a much smaller portion of the United States, we lead in the deaths of cancer. So why do we die more from cancer than everybody else? Why is that? We are not getting the proper health care. And by the time you get to these doctors and scientists on this call, our cases are so advanced and so bad that so much has to be done. So we have to get into these communities and we have to put our hands to it, give our time, ourselves, and help solve some of these problems. I just wanted to say that.
You are spot on, Arnold. Thank you so much.
Yes.
Viewers, educate yourself. Each one teach one, like we used to say back in the day. And let's advocate, advocate, advocate. Until next time, thank you so much for joining us for the Black Scientists Cooperative Podcast. Good night.
Good night.
Good night.
Deep flows like a breeze flowing through me, from my head to my feet. Your love runs smooth, ooh, it soothes, and you're making life bright. I'm so glad that you're mine. You're mine. Yeah.